You are now listening to Nailed It, the Orthopedic Surgery Podcast.
Well, I guess what function does the tendon itself have? I always, hear that it can help, with medial arch support, but what is the function of the posterior tibialis tendon?
So, I mean, specifically, it inverts, secondarily, it plantar flexes, but primarily it inverts and supinates the foot. But the reason mechanically, that's important, and this kind of gets the whole gait cycle, is we talk about, the foot position and its relation, to those transverse tarsal joints and what that does. So when you invert the hind foot, what that does is that it locks that transverse tarsal joint. So it essentially gives you a stiff lever arm in order to push off on. So that's why it's important in the gait cycles, because it gives you a stiff lever arm, which helps you with push off.
Okay. And we're talking about, where does it insert, just for anatomy, for those that are just
so
where does it insert?
Everywhere. So it's more important where it doesn't
much.
insert. I think that's the easier thing to remember is that,
Sure.
I mean, it really, other than the first metatarsal essentially, and, the talus, I mean, it's really pretty extensive. We talk about primarily the one we always, refer to, and accessory navicular, et cetera, is that medial navicular tuberosity, but it also extends plantarly and wraps around the plantar aspect of the foot. It attaches to the cuneiforms. It attaches to the second through fifth metatarsals. And so it has this really broad attachment plantarly to help, again, support that arch.
Okay. And so when you talked about the posterior tibialis function, you mentioned, I'm just repeating, that normally that posterior tibialis tendon helps lock the transverse, I'm blanking, the
tarsal joints,
the tarsal joints, and that gives you that stiff lever arm in order to continue through gait, correct?
Correct.
And okay, so when you have, I guess, dysfunction of the tendon, what's kind of the physiology, like what are the changes that happen to the foot with posterior?
So a few different things. So when it stops functioning, then a couple things different happen. So eventually what happens is that the hind foot goes into some valgus because you don't have the posterior tib to invert the foot. So the hind foot starts to go into valgus. You also lose some of the medial support with that. So the foot can go also into abduction. And again, there are a couple different things that can happen in order to compensate secondarily. So if your hind foot goes into valgus, then in order for your foot to stay flat on the ground, and this gets confusing, your forefoot has to then supinate to keep your foot plantigrade. So, that forefoot has to adjust to what the hind foot is doing. And so the hind foot starts to go into valgus, the forefoot has to correct. And again, sometimes you get that abduction deformity through the midfoot as well.
Okay, so we get, just repeating, we get our hind foot that goes into valgus, and then in order to keep that stance, your forefoot supinates, but it can also abduct as well. Is that correct?
Correct. Yep.
And how often, because you read about it and you'll see, like, eventually with increasing valgus, the fibula will go and impinge and they can get lateral ankle pain. Do you see that often in clinic? Like, is that something, do you ever see it get to that point?
I do. And it's interesting because, and just like it's described, often they'll start with the medial sided pain, and whether it just eventually kind of gives up or what, the medial side tends to dissipate with time. And then often they'll start presenting to you with lateral sided pain. And, what I find is that lateral pain can actually be from two areas. I think the thing we talk about a lot is the subfibular impingement, meaning that the calcaneus, as it goes into valgus, then, pinches against the lateral, the fibula, and, the peroneal tendons that are running right below that. But I think what I see honestly more frequently is kind of a sinus tarsi impingement. So if you think about the lateral process of the talus, it's that sharp point. And essentially what happens is that, as the foot goes into valgus, that edge almost starts to impinge in the angle of Geaney. And so a lot of people will have sinus tarsi pain and or that fibular impingement pain. And even to the point where I've seen people with fibular stress fractures, it's putting so much torque on the fibula, they get a stress fracture a little bit, like a Weber C kind of transverse issue there.
Wow. Wow, I didn't know that. Yeah, that's pretty cool. Well, I mean, that's not cool, but it's good to know.
Interesting. Yeah, good to look for.
It's interesting. That's what I was trying to think of. And so, what role does the Achilles have to, like, what part does that play in this, in the pathophysiology of this disease?
Yeah. Well, and the question is what comes first, right? And I would argue that most people, over 15 have a tight gastroc, other than those that stretch regularly. But, what happens is that as the calcaneus goes into valgus, the distance right from the origin to the insertion of the gastroc gets shorter because the calc moves laterally. And so, inevitably the gastroc's going to shorten. So it does that. The other thing that happens, and this goes back to what we talked about earlier with the fact that the posterior tibial tendon, when it works, is inverting right through the tailnavicular and the CC joints, and it's locking it in. So when it's not working, that whole midfoot's essentially unlocked. So what happens is that you get some dorsiflexion through those transverse tarsal joints. And so you get this compensatory dorsiflexion through the midfoot. So again, it means that the gastroc and the Achilles doesn't have to work as hard because you're getting dorsiflexion through the forefoot. So it kind of compensates for it as well.
Oh, okay. No, yeah, that makes perfect sense. And I love how you broke it down like that. It took me a while to read and like sit and look at it to understand it, but then you just broke it down so clearly. Yeah,
the way I always remember it. Yeah, locked in. Just remember locked in, right? In inversion, it's locked. That's how I remembered it as a resident. I pass that on because that's an easy way to remember it.
That is a gem by Dr. Geaney.